Welcome to Module 1 in the NPSF Certified Professional in Patient Safety Review course. Each module in this series addresses one of the 6 patient safety domains that are included on the CPPS exam. This module will discuss the importance of defining and identifying a culture of safety within a healthcare organization. This material was adapted from a presentation given at the 16th Annual NPSF Patient Safety Congress. The presentation was given by Karen Fresh, Chief Patient Safety Officer, Duke University Health System, Regina Hoffman, Patient Safety Liaison, Pennsylvania Patient Safety Authority, and Judy Milne, Patient Safety Officer, Duke University Hospital. The content outline for the culture domain is A. Assessment of patient safety culture. B. Raising awareness. And C. Promoting cultural change. The items in the content outline are addressed in 8 objectives. 1. Describe patient safety culture. 2. Discuss elements that contribute to a culture of safety. 3. Discuss the value of error reporting. 4. Describe response to adverse events and unexpected outcomes. 5. Discuss the development and execution of an education plan for patient safety. 6. Explain a culture of accountability. 7. Outline considerations for driving culture change. And 8. Describe patient-family involvement in a culture of safety. Let's begin with the definition of culture. You've probably seen quotes like this: "Culture eats process for lunch." But that really is the essence of the fact that there is power in culture and how it influences the ways in which people in a work environment behave. There are a few different definitions of what culture really is. In the 1970 book, Man-Made Disasters, Barry Turner used this quote: "Effectiveness of organizations lies in the way in which they are able to bring together large numbers of people and imbue them for a sufficient time with the similarity of approach, outlook, and priorities, to enable them to achieve collective, sustained responses impossible if a group of unorganized individuals were to face the same problem." However, this very property also brings dangers of a collective blindness to important issues, the danger that some vital factors may be left outside the bounds of organizational perception. So basically, what he's saying is that culture is the similarity of approach, shared values, norms, and perceptions, and those are the raw materials of culture. It's how we do things here. It's what's expected here. An important piece of his definition is that last sentence. That collective mindset sometimes can blind a whole group of people to deviations they're taking from normal processes. You're probably seeing that in your work. Some of the other modules in this course talk about that further. Through normalized deviance, a whole group of people can shift away from an expected way to perform, and that the social pressure to do so is part of the culture. Is culture what an organization is, or what it does? Externally, the organization is perceived or understood by what it produces. But internally, when you're working in an environment, it's more about who that organization is and how do we do things here. It's a combination of the 3 major gears shown in this slide. An organization is about its shared values, or what's important, the beliefs and how things get done, and the behavioral norms. All of these elements say a lot about the culture. So you can have policy, protocol, and mandates, but when you go down to the granular level of the organization, you really see how the culture is influencing the way the work is being done. The organizational structure and control systems, which are represented in the slide diagram by the purple box, to a large extent are mandated in a healthcare situation. We have regulations that guide us and best practices and evidence-based practices that we may apply. But when you get down to the interface with the patient, it's the sharp end of the culture, or the way we do things here, that creates the social pressure that sometimes causes changes in what we're expecting. Another view of culture comes from Edgar Schein. shared basic assumptions that are invented, discovered, or developed by a given group as it learns to cope with its problems of external adaptations and internal integration in ways that work well enough to be valid and therefore can be taught to new members of the group as ways to perceive and feel in relation to those problems. Again, what we're talking about is that groupthink, and element 5 can be taught to new members of the group. As people start to be taught the way we do things here, they'll start to behave in particular ways you may not be expecting. We need artifacts and visible markers that provide tangible evidence of the values that we're trying to use to drive the direction of the organization. And those are the points you want to understand, because if you want to move your culture in a particular direction, it's those artifacts and visible markers that you're going to want to move or change in order to drive the direction. It's interesting that successful organizations are referred to as having a small number of values. This helped rally their staff around the values and keep them on a particular path. So from that core, people understood how to perceive and respond to situations. Organizations that have too many values may not be able to keep people organized around the direction they're trying to take. James Reason documented 7 elements of an ideal safety culture in his book, Managing Organizational Accidents. First, regardless of who the leader is, if you have a strong culture, it will persist and should be sustainable regardless of leadership changes or external pressures. Second, from high reliability science, you have respect for threats that can breach various defenses. This requires paying attention to small signals that warn us that there's something that's not working well in a process. Third, the culture is well informed through a great data collection system that is telling the culture and the system to take action when necessary. Fourth, frontline staff are engaged in reporting errors and near misses. Fifth, we have built a culture that has figured out how to deal with error by balancing accountability and blame. It's a just culture. Sixth, the culture is flexible and respects expertise. This means not just bowing to hierarchy, but engaging people who may have more knowledge than someone in a leadership role in some circumstances. And finally, one of the most important elements is that the culture is willing to learn. It has adopted ways to share information obtained from errors and help people learn from errors and not have that be a punitive situation. We've learned from Brian Sexton and a group at Hopkins that culture is local, so if you think about organizational culture, you're not going granular enough. We know that work teams in local settings can be very different from unit to unit. There's higher variability between units than there is between organizations. We also recognize that there is more variability between roles. If you've done culture surveys before, you will usually see that physicians rank teamwork stronger than nurses do. They think collaboration and communication is more effective. And other roles have variations in viewpoint as well. And finally, frontline staff will have very different views than management, so don't rely on management to tell you what's happening in their unit. You really need to talk to frontline level individuals to gain better perspectives when interpreting safety culture data, because they have the real experience to guide how you interpret the results. Accredited organizations are required by the Joint Commission to carry out safety surveys on a periodic basis. Some organizations have moved towards an 18-month cycle rather than an annual one, because by the time you get the results and analyze them and start to work on the action plan, it's time to survey again. The most commonly used surveys are AHRQ Hospital Survey of Patient Safety and the Safety Attitudes Questionnaire that was generated by Brian Sexton and is currently managed by Pascal Metrics. Both of these instruments are broadly used, not only in the United States, but internationally. They've been a source of great research, reinforcing the concept of the local nature of culture and the differences between various groups of providers and frontline staff. The Hospital Survey of Patient Safety Culture, referred to as HSOPS, includes 14 elements, which are broken into 3 main components. 1. Unit-level aspects of safety culture. 2. hospital-level aspects of safety culture, and 3, outcome variables. When that data is analyzed together, it gives a really strong picture of culture in your organization. The emphasis in this survey is on patient safety issues and event reporting. The Safety Attitudes Questionnaire, referred to as SAQ, has a little different twist. It has 2 primary domains, which are teamwork and safety. SAQ's 3 supporting domains also reflect what the culture is doing: stress recognition or threat awareness, resilience, and work-life balance. So what's important about this is not what instrument you use, but how you deal with the data and how you structure your survey. First, you want to get high response rates. 60% is the target threshold for reliable data, and that's at each work unit level. Second, what is your leadership structure or strategy for how you will use this data? Before going into the survey, you need to know what's to be expected of each clinical unit and how they'll respond to and analyze the data. Will everybody need to have an action plan, or will we target response based on the results? If people in lower tiers of response and performance will be required to have action plans, but people with excellent results will not be required to, that's something your leadership will have to identify. Will you have whole organization response based on a particular domain, where you may have strategies that cross the organization, or will you just keep that at a local level? And what kinds of analytics and support for the analytics do you have as you deploy the results of the data? Finally, as people start to respond with their action plans, how will you disseminate best practices? How will you teach other people across the organization when a particular work unit has had a great response and has come up with a great strategy for improving their culture? So again, using your culture data requires planning and leadership support and buy-in. Another marker for your culture is near-miss reporting or close call reporting. If the voluntary reporting system is very robust, it's probably a good signal that your culture is strong and that people have been reporting when they see concerns and safety issues, whether they've reached the patient or not. So that might be a good alternative way to talk about your culture of safety. You could have a variety of measures to look at this: the number of reports that are near miss or close call. But that reporting system has to be supported by culture concepts that are just. If people are punished for reporting, you won't get the information you need to drive improvement. If occurrence reporting is used as a weapon, reporting will go underground. Developing feedback loops to staff who do report are one important way you can enhance and encourage reporting. Finally, at a very high level, has patient safety been made a strategic priority in your organization? Is it embedded in the values? Do you have those markers and methods that will engage staff and keep them engaged in the long haul in patient safety activities and methods? When it is embedded in the values and priorities, patient safety can thrive. Now we're going to discuss raising awareness of patient safety through education. We talk about safety and what that means, but how do we educate our staff about what that means? It's not good enough to just go out there and say, "Hey, be safe." There are a lot of things we take for granted that staff may not know. So as you go through this course, your goals are: 1, to be prepared for the exam first and foremost, and 2, if you pick up something to take back to your facility and make care better and safer, that would be a double win. So let's address the science of patient safety and what you should be thinking about incorporating into your education plans in your facility. Some of what we'll talk about is standardization, learning from errors, human factors, and teamwork training. We'll also talk about error reporting and near misses. The module will wrap up with disclosure and apology. We know that standardization is really important in error reduction. The key is making sure you have buy-in from the people who need to buy in first, whether that's administration, leadership, or physicians. If key people are unwilling to standardize and you don't have support from leadership, you're left spinning your wheels. But we know that when we standardize within departments, we have error reduction. When we can carry that throughout an organization, we have further error reduction. When we carry it throughout the industry, that's really where we want to be. And when you talk about standardization and educate your staff, use stories. I think storytelling is really important. One good story is about the color-coded wristband. If you work in a facility today and you're using colored wristbands, you may not know that which colors are used for what is pretty standard across most of the country. But that all started from one event that actually happened in Pennsylvania. It was a near miss. There was one nurse who worked at two facilities. She worked full-time at one, per diem at the other. In her full-time hospital, yellow meant restricted extremity. She went to work per diem at the other hospital and had a patient with a restricted extremity, so she put a yellow armband on them. But at that hospital, yellow meant DNR. The stars aligned, as they often do in healthcare, and the patient coded, and the team almost didn't resuscitate the patient. Someone looked at the chart and realized the patient was a full code. They carried out the code, and the patient was resuscitated. Now, in most places across the United States, people are using the same colors. When you're thinking about your education plans, think about how to make it hit home with your staff. Checklists are a list of actions that should be performed to optimize patient outcomes. Checklists have had many challenges in this highly educated industry because many professionals believe they have the capacity to remember what to do. But we know that as humans, we are going to make errors, so checklists are one way to make sure we do all the steps in the process that we need to do. We cannot rely on memory in an environment bombarded by interruptions and distractions, intricate processes, and technology overload. There is sound theoretical basis for checklists, and we have a history of success with patient safety and use of checklists. Specifically, there are surgical safety checklists, which have shown a significant reduction in wrong site surgeries across the country. There are also various bundles and evidence-based guidelines, such as those for central lines and urinary catheters, that are proving to significantly help reduce infections. For example, the checklist designed to reduce central line-associated bloodstream infections used in the Keystone ICU resulted in many units eliminating these infections for months. So when you educate about checklists as a safety strategy, reinforce why it's important, using examples and data if available. And again, what happens when you have people who aren't going to use the checklist? Seek leadership support as you adopt this strategy, and anticipate that there will be resistors. Errors are opportunities. Near misses are bigger opportunities. What do we do with those? Do we do enough root cause analyses or RCA? Are we doing them on near misses? When you educate your staff on lessons learned, do you educate them on the RCA process? Do they understand what a root cause analysis is before they go in? The more people you train in RCA, the better off you'll be, as they will initiate local event investigation more effectively. Once we dig up the roots of our problems, do we talk about what's underneath that's feeding all those roots? Do we get to common cause and educate our staff about what that is? People don't often get to that point because these are really tough things to look at. If your culture is supporting errors or you have poor communication, those are harder fixes than just changing the process for medication reconciliation. What do we do with the causes when we find them? Do we have a structured plan to go back and educate our staff as well as the other colleagues on what our lessons learned were? It's important to apply the lessons learned in all areas that could experience the same error. It's also important that we educate staff about human factors. This is a discipline in and of itself. Human factors science is different than human error. It's really about how we as humans interact with our environment, with each other, with the equipment we use, and with our processes. It's also about how those processes can make it either really easy to do the right thing or really easy to make a mistake. Do we educate our staff on the basics of human factors? Do you have managers who don't understand human factors science? Who are the people in your organizations who are designing processes that are bringing in new equipment? And do they know the concept of human factors? Some basic training for those folks and your frontline staff would be very helpful. This is a popular topic for frontline staff when you give them examples. When cars were first invented, brakes weren't always on the left. Early on, that wasn't standardized, so that sets frontline staff to thinking, wait a minute, what equipment do I have that could be a different vendor or brand that could easily be interchanged? You will hear teamwork-related themes throughout this course. All organizations should have some form of teamwork training. As healthcare providers, sometimes we are very focused on our task and we miss what's going on around us. Strong teams help avoid the errors that can ensue from task fixation. Team STEPS is one of the most visible and utilized models for team training in healthcare today. It was developed by the Department of Defense and the Agency for Healthcare Research and Quality, or AHRQ. You can find Team STEPS toolkits on the AHRQ website. Another strategy to enhance teamwork is through the Comprehensive Unit-Based Safety Program, or CUSP model, which was designed to make patients safer in med-surg units. CUSP puts multidisciplinary frontline team members together to solve local problems and improve the safety culture in their local unit or team. An important part of teamwork is situational awareness. This is not just an intuitive practice for humans. Training in situational awareness is valuable. Such training teaches the team to focus on the bigger picture and one's surroundings. It helps to prevent errors that ensue from task fixation. Another common approach to teamwork training is to use simulation. Simulation training can be used in all organizations, both large and small, without high levels of sophistication and equipment. It is practicing and preparing for critical situations. Of course, the more our teams practice, the better we get. Another important element emphasized in team training is communication. SBAR is just one example of structured communication that helps teams to be more effective and safe. As a patient safety professional, assess where formal team training could benefit your organization, then find the right approach to accomplish that. Your strategy may be organization-wide or very local and customized. When educating staff about error reporting and near misses, make sure to provide clear expectations about when and how they should report. We do a good job reporting and investigating events that do harm to people, but zeroing in on those near misses and making sure we review those things routinely with staff is often excluded. Staff need reminders. They need to hear from patient safety professionals and their leadership that it's okay to report. Providing feedback to staff about trends and patterns in the reports and improvements that have resulted also encourages them to report. Most importantly, give them examples of near misses in your facility or those that have gained national media attention over the years. How does your safety culture support disclosure and apology? What do you require be disclosed? And do staff and physicians understand those requirements? Do they support transparency with your customers and within your organization? What are some of the psychological barriers to disclosure? The biggest barrier is fear. Is it fear of retaliation? How will the person react when you tell them about the error? Some people might say, everything turned out okay, so we don't need to report it. Or, the patient was going to die anyway. We have many providers who say, let's not cause the family any more pain. There may also be legal barriers. In some states, you don't have protection if you apologize. However, some states now have apology laws requiring apology and disclosure. This is a growing trend. Hopefully, you do have a policy and a model for disclosure. Be sure that you are teaching on that model. Do you have a team model, or does it depend on a situation? Are all members of the team trained for disclosure, or do you offer just-in-time consultation? Make sure you take into account your patient expectations. Every patient expects to be told the truth. Your model should outline the process and the conversation that will take place. Disclosure training is a good focus for simulation. Make sure everyone understands their role. Who is going to talk about what before you talk to the family? Have a conversation outline that takes into account special needs such as language barriers, hearing, or other disabilities. Outline the steps for follow-up conversations with the patient's family and document the conversation somewhere. Seek guidance from risk management about where such documentation belongs. Here again, a conversation outline is an important tool. Think about what you want to say before you go in and practice it. Give staff opportunities to practice, possibly through simulation. Key elements of the outline include talking about what happened. This should convey regret in a genuine way. Patients and families generally want to know what steps you have already taken to prevent a recurrence. They want to know what you are doing for this patient and what you are doing for other patients. Explain how you will make sure that the current patient doesn't get hurt more. Describe the change in the patient's plan of care and what it means for length of stay and aftercare. Make sure the family leaves with someone's name and contact information, and make sure the support is available. Remember also, in disclosure, that it's okay to say that you don't have all the facts yet. The timing of a disclosure is important. You want to have enough information to accurately respond to concerns the patient or family may have, but you don't want to delay the disclosure while you are waiting for all the information that may unfold. Risk management will likely play a role in disclosure and can help you judge that timing. Always provide the family with information needed for appropriate care decisions. Ineffective disclosure doesn't really serve the patient because important information is not communicated. Successful disclosure cannot be measured solely by whether or not the event ends in a malpractice claim. In other words, just because you have a malpractice suit does not mean you had an unsuccessful disclosure and vice versa. We don't disclose in order to prevent malpractice. We disclose because it's the right thing to do. We'll wrap up this module with a discussion of accountability and the concepts of behaviors and choices. We often think about psychological safety as the belief that we won't be punished or humiliated when we speak up. We often think of an angry physician yelling and pounding the table and everybody being intimidated. When you think of the nurse's side, though, you think of the nonverbal behavior, like rolling the eyes, and that can be just as powerful. So psychological safety is about your behavior as a leader, setting the tone for an environment that invites people into the conversation. Psychological safety is really a key component of culture. Traditionally, the culture of medicine is one that is blaming and punitive. Patient safety is about the transition from a culture of blame, not to one that is blame-free, but to a culture of accountability. We recognize we're human beings, and we recognize that part of being human is making mistakes. It's not wrong to make mistakes. We all know that. But the point is, we need to be transparent and recognize the fact that we need to talk about it and learn from it. That's the environment we want. If you repeat a mistake a couple of times, that's a problem. It's the consequences that we really need to mitigate so that we can prevent harm. We can't prevent errors, but we can prevent harm. Making choices is another part of being human, so models of accountability are developed to think about making choices, which we do all the time in healthcare. And many times, individuals make choices and they don't even realize they're adding risk. The risk isn't in the system, it's sometimes in the people. That's why we have accountability models for professionalism, to help us rein in some of the choices that people make. So we want to talk about a professionalism model and models of accountability that help us manage at-risk behavior that individuals don't realize they're undertaking. We also want to have a way to deal with reckless behavior. These are behaviors that need administrative consequences. Healthcare employees who are reckless in other areas of their lives may tend to be reckless in their work. And we need to do all we can to prevent this type of behavior. Reckless behavior is different than the at-risk behavior that people may not even realize they're engaging in, or that they may think is justified. It's the at-risk behavior that may be the most difficult to manage because the individuals may not even be aware of it. It may be a conscious choice to do something that's outside the law, but there's a reason why the person chose to go outside. So step outside of healthcare for a minute and think of it this way. The speed limit on a road is 65. How fast do you go? Let's pick 70. Everybody is zooming past you. You're in the slow lane, so most people are going 75 or 80. So now you're going 80, and then some guy whips past you. He must be going 100. The law says to go 65. We all know it. But many of us have gotten a ticket when we chose not to obey the law. You might be within that realm of normalized deviance, not quite following the law, but deviating just a little bit from it. And you keep pushing the boundary until it's blatant recklessness. There's a line, right? So think about that as you bring it back to healthcare. What if just 1 or 2 times you don't wash your hands, or just 1 or 2 times you don't do a double identifier? These are safe practices that we do each time. If we fail to do these things, there's not a conscious intent to hurt someone, but there is a conscious awareness that we're not really doing what the law says, but neither are our colleagues. So as you think about normalized deviance, How do you address that risk-taking? Are you aware of specific examples where drift is occurring in your organization? How can you make the consequences of those practices more visible? If you are using lessons learned from actual events, examples from your error reporting system, spot audits, and feedback loops on high-risk processes, then you are making the potential impact of at-risk behaviors more visible. Reducing drift, normalized deviance, and at-risk behavior requires coaching and awareness. Rennie M. Alberti is a retired general and professor of medicine, physiology, and ergonomics who performed research on human error and risk management. He is a founder of Crew Resource Management. He migrated from aerospace to healthcare and added to the research base on systems approach and resilience as it relates to medical error. Dr. M. Alberti's model of normalization of deviance suggests that violations have both positive and negative aspects. On the one hand, they occur frequently. Increased system performance and individual satisfaction are mostly limited to practices with minimal safety consequences and therefore are often tolerated or even encouraged by the hierarchy. On the other hand, extreme violations can lead to real danger or actual harm. Migration to boundaries explains the mechanism by which the deviance occurs, stabilizes, regresses, or progresses to harm. The model suggests that violations are unavoidable because system forces and deviances are markers of adaptation to this dynamic continuum. Violations cannot be eliminated, but they can be managed. As you observe deviation, you should be thinking about what incentives exist for people to deviate or begin to take risks, and what barriers are in place to prevent this deviation. Evaluating the strength of barriers, as in the Swiss cheese model, is an important step in decreasing risky deviations. Then there is blatant recklessness, driving 100 miles per hour, driving and drinking, those things that are just clearly in the rules and that really require administrative consequence. We have a certain accountability because we are in a business that involves taking care of people and because our choices can affect their lives. So we will end with 2 thoughts about models for accountability. One model comes from Dr. Gerald Hickson and his team at Vanderbilt. It's called the Patient Advocacy Reporting System. This system emphasizes professionalism. This means there is a group of individuals who understand the importance of self-regulating and group regulating. There is a normal behavior equated with being a professional. Most everybody lives according to those norms. This is often a physician model, but could be any healthcare providers. Most people regulate themselves with a little bit of coaching along the way. A few choose to drink and drive or whatever the egregious behavior. There needs to be a consequence for that. There might be consequences that require somebody not being in our healthcare organization if they choose to continue with risk-taking behavior. For a smaller number of people, that risk-taking isn't a conscious behavior. They don't even realize they're going 72 and now they're at 75. They put those safety rules a little bit behind, and they don't even hear themselves when they come across with the punitive tone or give the nonverbals that also send a powerful message. These people require coaching. Healthcare is about human performance. Think about athletes and how much they're coached about how they're performing. They want that feedback. We don't do that in healthcare. So sometimes when a person wants to manage their behaviors, they need feedback. They need coaching. Generally speaking, we don't do that very well in healthcare. So this professionalism model is about the fact that most people regulate themselves, pull themselves back in. In the patient advocacy reporting system model, they may just need simple informal coaching. Let's have a cup of coffee and just talk about it. Because once we hold up the mirror and help people see how they're coming across, that's all it is. But if the risk-taking or demeaning behaviors continue, then you escalate the response that's required until you get to the top of the pyramid. Another accountability model to be familiar with is David Marks's just culture. There's simple human error, at-risk behavior, and blatant recklessness. We talked about simple human error, and it's part of us. Fix the system. For at-risk behavior, coach and mentor, point out, hold up the mirror, and expect a response. And if there continues to be at-risk behavior, or worse, blatant recklessness, then there have to be consequences. So, just culture is a system of shared accountability that takes involvement from all of us. It takes leaders at healthcare institutions who are really accountable for the safe designs, for the safe processes, for setting the tone, and for creating the expectations. We can't hold people accountable until we make the expectations clear. Once you do that, there is a responsibility in every one of us, as clinicians and as people who work in that healthcare facility, to be accountable for our own behavior, to know that we are never going to be perfect, but we do have choices. And to be aware of that and think about that in terms of professionalism in our behaviors. Consistent application of the principles is foundational, so that's the accountability side of culture. Thank you for listening. This concludes Module 1.